just testing, but also the physical conditions inside the home, and also the way in which there is dialogue between staff and management, so that if staff are feeling unwell and the sense that they may have COVID, that there is no kind of penalisation if they have to take time off, which means a lot of trust between managers and staff and regular dialogue. Comprehensive approach, testing frequently, and in addition, real attention to what is actually happening inside these facilities to try to reduce the risk and maintain the health of the residents.
Doctor, can I ask you, can COVID-19 be passed through breastfeeding from a mother to her newborn child? Concerns have been raised to me, especially if the new mother is asymptomatic, and concerns whether she should continue feeding her baby herself.
There'll be many answers to several of your questions, to which I will have to say either I don't know, or quite often also we don't know, referring to the broader public health community that is based in WHO and through its networks. I personally don't know just how often COVID could be transmitted in breast milk. I have seen reports that suggest this is possible. But I want to really make the point, which is emphasised very strongly by the World Health Organization, that we must do all we can to promote breastfeeding of infants when they're born. And we must not use the fear of possibility of somebody not knowing whether they have COVID as an excuse to perhaps encourage early cessation of breastfeeding or non-starting of breastfeeding. So I do really want to encourage continued breastfeeding wherever possible, and I want to make the point that there is still a lack of understanding on just how important transmission through breast milk is for this particular virus. If I have more information, I will come back to you. But I've just been, my colleague here who's helping me has also said to me that there is still real uncertainty about how much COVID might get into breast milk. It's a big research question, and also a real request that there is a good attention to breast hygiene in the normal way, just in case there is the possibility of transmission as a result of having contact
Thank you, Dr. Nabarro.
Virus on the breast.
Thank you. I'd now like to ask the next speaker, Deputy Matt Carthy of Sinn Féin. Is it for 8 minutes, because we have to reduce it? Yeah, thank you.
Thank you again, Chair. So Dr. Nabarro, thank you again for your contribution here this morning and for joining us. There was reference to nursing homes, and you mentioned the fact that quite a number of states have high percentage of cases that of fatalities that have occurred within nursing homes. But at the same time, the figures you mentioned ranged from around early 20% to the situation in Ireland. Is there anything specific that you have been able to ascertain that those states that have had a lower instances or occurrence of COVID-19 within nursing homes have done that perhaps should be emulated in other countries and perhaps weren't emulated?
Thank you very much indeed. I want to start by commenting on the numbers. You see, some countries were really not very comprehensive in their counting of the deaths in residential care and nursing homes, I'll use your term. And so, for example, they only counted deaths if the patient had actually been transferred from the nursing home to a hospital and then were tested in the hospital. Other countries were very careful, saying, well, we'll count a death in a nursing home of somebody who tests positive for COVID if we conclude that actually the COVID was contributing to the death. Other countries have said, well, we'll actually count all deaths in nursing homes where there is COVID found, even if we're not sure whether the COVID contributed to the death. What I call the wide circle of inclusion. Ireland has probably got the widest circle of inclusion of all the countries I've studied, which may be one of the reasons why there's a relatively high rate of deaths in nursing homes associated with COVID in Ireland compared with some other countries. Secondly, as far as I can tell from the analysis I've done, Ireland moved pretty quickly on a number of issues, particularly trying to get PPE in its various forms to the staff in nursing homes, and secondly, in restricting visitation in nursing homes, recognising that visitors were a primary way of bringing in the virus. I think possibly Ireland might have been one of the faster countries to introduce this. So at the moment, I'm not actually thinking that there's something that Ireland has not done. I just think that, one, we've got a very honest counting of numbers, and two, as with every country, this has been quite a struggle, but it seems that Ireland did pretty well. Over.
You mentioned, Dr. Nabarro, the situation regarding some workplace settings, and I think you referenced meat and fish packing and implants of that nature. Is there any piece of advice that you would give to governments with regard to, say, for example, meat factories or meat plants that would help address the issues that seem to be coming from those particular settings, considering there's evidence that suggests that clusters within the communities close to those factories have also shown a high prevalence?
Thank you very much indeed. If we look at meat plants throughout the world, particularly industrialised meat plants where there's an abattoir at one end and the packs ready for the supermarket come out at the other end, there do seem to be sort of features of these settings that make COVID transmission particularly likely. First of all, the people who work there are often poor and may not necessarily have good access to healthcare. I think in Ireland that's less of a problem, but in other countries it really is a big issue. Secondly, inside the plants, people are quite densely together. The ambient temperature is low. It's noisy. They have to shout at each other to be heard, so they have to get close. And for some time, there were delays in getting necessary protective equipment to them. Thirdly, where they change out of their work clothes into their home clothes, may be a very condensed area, and there may be close contact. But fourthly, often they live in quite packed accommodation, especially if they're migrant workers, and they may share transport to and from. I would suggest that anybody who's working in meat and fish look very carefully at all aspects of the production system from an infection control point of view, and might try to make sure that every action possible is taken. And if this does mean that there's going to have to be an increase in the price of meat, then so be it, because I think that most consumers will understand if they have to pay a bit more for their joint of meat, if this means that workers are kept healthy.
There's a debate ongoing in this country. I don't know if you're aware of it, but I suppose to contextualise it, in essence, I think our strategy is to suppress the virus. There are some that have argued that because we are part of an island nation, it is possible for countries like ours and New Zealand and Greece and island nations to actually eliminate the virus. Do you think a strategy of suppressing the virus as we're currently employing is sufficient, or do you think that approach still leaves vulnerabilities? And would they be addressed by a more comprehensive elimination strategy?
Thanks. I did see a report in the Irish Times, I think it was yesterday, explaining what this was about, and I know there's been a letter signed by 1,000 scientists. I want to be fairly precise on this one. Yes, ideally, nations try to completely suppress the virus. But the reality is that there's a lot of virus in the world, and nations have to be able to connect with others for business, as well as for tourism, as well as for family connections. And it's just not going to be possible to completely insulate Ireland, even if we look at the whole island of Ireland, south and north, without really putting huge constraints on the movement of people and also, therefore, on the economy. So my point of view is that a responsible way to go about this is to do everything possible to get as low a level of infection as is achievable, in particular by making sure that all over the country, at the local level, there is the capacity to detect people very quickly if they've got COVID, and then to isolate them, to find their contacts and isolate them, and particularly if an outbreak does build up and you've got a cluster, to bring in people and in a sympathetic and dignified way to suppress that cluster and make sure that there is infection control put in place. That, I think, is going to be the pattern of every country in the future. And I think to go for complete eradication is certainly a desirable, but is really also possibly not feasible in the current circumstances, especially as the island of Ireland is consists of one whole nation and part of another nation, and there are all sorts of factors that will restrict the degree to which.
I just have one more question in limited time, if I may. We're now currently coming out of lockdown, easing restrictions, as you will have noticed. There would be fears, particularly in relation to if there were ever a need to reignite the control or lockdown measures, whether or not the same level of public support or buy-in to that type of scenario would be there as possible. So what are the particular warning signs that you think we should be looking out for in relation to evaluating the success of the easing of restrictions? If you could, very briefly, thank you.
Yeah, I know it's got to be brief. I would find it really surprising if Ireland has to go into a complete national lockdown again. I think there will be local areas where perhaps clusters emerge, where for a short period of time movement restrictions will have to be imposed. But the pattern of the future will be picking up outbreaks so fast and dealing with them very quickly because of a high level of local organisation. And I personally believe that total lockdown is highly unlikely.
Nabarro. Deputy Burke.
Thank you very much.
5 minutes.
For your presentation. Can I just ask you, from your own experience, in relation to hospitals and going forward from now, a lot of the procedures, the normal procedures that are done in hospitals are now resuming. Should every person who is admitted to hospital be tested? In particular, should every person, before they go for a medical procedure, an operation, be tested within the hospital setting?
Thank you very much indeed. Of course, a decision on something like this has to be made by the national government. So what I'm going to do is to give you what I would be thinking about if I was in the situation. And the reality is that we're still uncertain how many people with COVID are without symptoms. And certainly we also are seeing people able to transmit the virus before they have their symptoms. And so my own approach, particularly in healthcare settings, would be quite liberal with regard to testing for staff and for patients, whether there are inpatients or outpatients, because I would not wish there to be an opportunity for the disease to start spreading in hospitals. And I also want to do everything possible to encourage the creation of facilities that can deal with non-COVID care. And it's important to make sure that COVID doesn't get into those if possible.
And around 31% of those infected with COVID-19 are healthcare personnel. I'm just wondering, in comparison to other countries, where do we stand? And has it been identified in any other country as to why it's higher or lower, or is there something that we're not doing here, or that we're not working hard enough in relation to giving and working with staff on that particular issue?
Thank you very much indeed. Yes, it's quite a high number of the people reported with COVID are involved in providing health care. And so this is an area that I think does need continued investigation. All the time we're seeing that there are multiple reasons why health professionals get exposed and get ill, and they're not always to do with the fact that they are picking it up where they work. They may actually be picking it up in the community. But let's just look at the care situation. Number one, obviously protective equipment's got to be there. My understanding is that Ireland, like many other countries, has had difficulty at the beginning with ensuring adequate supplies. But according to my information, these have been dealt with pretty comprehensively and in a satisfactory way. Number two is trying to also make certain that within the hospital facility, every action possible can be taken to reduce the risk due to the physical layout of the place that COVID spreads. Now, in countries that have had hospital buildings that are quite old and that have not been purpose-built and are not ideal for dealing with infection control settings, this can be a bit of a challenge. I'm seeing that from many other countries around the world, that it just gets tough. Last point is just to say that I do understand that the government is looking extremely hard at ways to try to reduce as low as possible the risks to health professionals, and I would commend for that.
That's in relation to a UK report out this morning showing is that 78% of those who contracted COVID and 62% of deaths in UK hospitals related to people who were overweight and obese. Is that replicated in other countries, or is it just something that's in the UK only? And in particular in relation to underlying conditions, what kind of percentage of deaths have occurred where there's been already underlying conditions?
Right. I don't have the absolute figures on that right immediately, but we'll be getting them because. But I want to say the following: most deaths, as we just discussed, are in older people. Often there are also deaths in people who've got diabetes and hypertension. If you're male, you've got a higher risk. If you're obese, the risk seems to be much higher. If we bring it all together, an old person who's got diabetes, who's obese, and who's a man has a super high risk. This is a global phenomenon. It's not just restricted to Ireland.
Now I'd like to call upon Deputy Duncan Smith of the Labour Party.
Thank you. Dr Nabarro, I have 3 questions which I'll just list out, and if you can answer in the time, I'd appreciate. Is there any emerging analysis to say that there could be a seasonal element to COVID-19 and that we could see strong re-emergence of it in the winter? Question 2, you seem to be a strong advocate for the use of face coverings being necessary on public transport and in shops. Can you point to any examples of countries that you would describe as being the best in class for their face coverings policy? And 3, where are we in relation to a vaccine and timelines in related to that? Thank you.
Thank you very much. Yeah, I think there will be seasonality with this because I'm absolutely certain that people will get more sick in colder weather. But we want to be clear, this is not like flu. It does look as though the virus is stable and it's capable of being transmitted in hot weather as well as in cold weather, and it's a threat, therefore, in the warm seasons. It's a coronavirus and not flu, and part of the issue has been to help people to start thinking in terms of a different kind of mindset compared with the flu pandemic. Continuous threat is the language I keep using. Secondly, face coverings really are necessary because people may well be able to transmit the virus before they develop symptoms of disease. So they may not know that they're sick, and therefore they may not know to self-isolate. And so the use of face coverings is important in situations where individuals are likely to be exposed to a lot of illness. So this is drivers on public transport, cleaners in situations where, for example, they're dealing with communal facilities like toilets, and also security guards, till workers in supermarkets. All these situations, the folk there are exposed to a lot. So they should be dealing with people who are using face protection just in case the individual they're dealing with is actually got the virus. Spain seems to be developing a good policy on this, and I'm impressed that there's been quite high uptake. And of course, all the countries in East Asia are familiar with this after SARS in 2003. There are going to be questions about the extent to which you can rely on voluntary compliance or whether you need to make it mandatory, and you didn't ask me about that, but I do think we need to try to push from saying people should do to people really must do, not just for their own sake, but for the sake of the people who look after them. Because more and more I'm getting worried about those who provide service being exposed by those who don't quite realise how risky they are. Personally, I want to be absolutely certain that any vaccines available for COVID are fully tested through the full regime of the different clinical trials that are necessary for vaccines to make sure they are 100% safe. Now, of course, there will be, if there are odd individuals with side effects, then it'll be up to governments to decide what degree of side effects they're prepared to tolerate. But we have got quite a widespread anti-vaccine movement going on in the world at the moment, which means that measles, a disease for which we've got a really good vaccine, is suddenly returning as a public health threat. So the safety part is super important. Secondly, it is going to be necessary to demonstrate to the public that the vaccines really work. And there are concerns that coronavirus will be difficult to develop an effective vaccine against. So I'm saying 18 months till we get going through all the clinical trials and get through the necessary approval stage, and possibly a year or even 2 years before everybody in the world can be vaccinated. I want to be sure that everybody gets a vaccine, not just those who live in countries that are able to pay for it. So therefore, between 2.5 to 3 and even 3.5 years before everybody who needs to has access to an effective vaccine.
Nabarro. Deputy Shortall.
I have 3 questions. The first, I'd just like to go back to the issue of face coverings. It's been suggested here that cloth face coverings aren't especially effective, aren't fantastic, I think is the way it was described. And I'm just wondering, what is your advice in relation to the quality of mask that is required? What is the optimum quality? Bearing in mind the limitations on the availability of hospital quality masks and other issues, what is your view on cloth masks and homemade masks? Secondly, in relation to the question of social distancing, and there's a lot of pressure in this country at the moment from the business community to reduce the distance from 2 metres to 1 metre. If we were to move to a situation of 1 metre, are there other issues that would be required to be put in place? And specifically, would we need to ensure that the wearing of masks was mandatory in order to go down to a 1 metre distance? And thirdly, my question relates to the issue of New Zealand, and I think we all look at New Zealand enviously, and you've already addressed that to some extent. But if we were to be stricter about the transmission of the virus from people coming into the country for whatever reason, what is best practice in terms of isolation, quarantining or testing at ports and airports? Thank you.
Thanks very much indeed. As I answer questions here, of course, I've got the WHO guidance in the back of my mind, but I'm also all the time trying to interpret that, hopefully within the context of Ireland as a country. That means I have to make assumptions, and also I'm having to be brief. And so please forgive me if at times I appear not quite to tune in with the underlying purpose of your questions. Right at the centre, and I think you got it in the way you asked the question, I want to stress, it's not one single measure that's going to keep the people of Ireland safe. It's having a comprehensive strategy that seeks to reduce the risk of transmission, whilst at the same time making sure that if outbreaks do build up, they're nipped in the bud really fast, and that there is special protection for the communities that seem to be at particular risk. Now, face protection are part of that comprehensive strategy. There are 2 sides to it. One is protecting people from being infected, like healthcare workers or people in other highly exposed situations. And there, the very sophisticated filtration masks, N95 or FFP, they stick over your mouth. They look like you've got a funny beak on your face. They are very useful, but they should be preserved. And so that's why there has been a move to advocating cloth masks, perhaps homemade cloth masks, for people who do want to try to be responsible citizens and protect others. And there, WHO has come out with guidance suggesting a 3-layer mask. Actually, it's quite complicated. Others are saying that all you need to have is multiple layers of ordinary cotton, but perhaps 5 or 6 layers rather than 1 or 2 layers. And others are saying, well, it doesn't really matter. What you need is just to have enough protection so that you're at least reducing the risk. My own view is somewhere in the middle. I actually do think multiple layers. I don't think they need to be special cloth, and I think what's really important is not so much how the mask is made, but how it's worn, and making sure there are not gaps, and absolutely making sure that people don't believe that a mask is working if they've got it under their noses. That is really unhelpful. And right at the centre of this is, don't imagine that just because you're wearing a mask, you are either got low risk yourself or you're protecting other people. You must be part of the comprehensive strategy, including physical distancing. And with physical distancing, this is a question of risk. If you're 1 metre away from somebody and they're coughing in front of you, you perhaps have a certain risk of being infected that is a bit less than if you were really close to the person. And if you're 2 metres away from the person, then the risk is further reduced. Based on various bits of data, we usually say you've got a 60% reduction at 1 metre, and then you've got something like a 90 or 95% reduction at 2 metres. And various people are using different risk figures. So in any situation, there is a balance of risk. On the one hand, you want to make sure that the necessary parts of the economy can be kept going. On the other hand, you want to try to reduce the risk. And all this is done within context. If there's a lot of virus around, then the physical distancing becomes really important. If there's not much virus around, then it becomes less so. I'm basically saying, please be at least 1 metre. And if you can be 2 metres, then that is a really good thing to do. And remember that there are certain actions like singing, which seem to be associated with even greater...
Thank you, Dr. Nabarro. Thank you.
Careful. Sorry?
Could I move on to the next speaker, Deputy Barry? I take it you're substituting for the Socialist Party People Before Profit. You have 4 minutes, rather.
Thank you. Good morning, Dr. Nabarro. I want to ask you about the issue of face masks and coverings. You mentioned earlier that you are more and more worried about people who provide services.
Yes.
This morning in Ireland, the leader of one of the transport workers' unions said that face masks and coverings should be made compulsory for commuters. Do you think that's a reasonable position to hold?
So the way you asked the question, it helps me, because yes, I think that is a reasonable position to hold because of what I've seen about the mortality risk of bus drivers and the concerns around people who work as attendants on stations, especially when they're underground or enclosed. So it's a reasonable position to hold. I'm not going to say anything more than that. I hope that's okay.
You mentioned there that you've seen evidence around the world of the risks to transport workers and mortality. Could you give us a bit of information and data on that?
Yes, I'd refer you to the UK study, particularly looking at those working in buses, suggesting that there does seem to be a surprisingly high mortality among bus drivers. And secondly, I've seen other reports, but I've not got numbers on them, of transport staff, particularly in bus or on station platforms in other countries. I'd need to send you that in writing.
I think you said earlier on that one of the countries that you work with directly or directly responsible for is Canada. Is that correct? Yeah.
Yes, that is part of my area of coverage. Yep.
Yeah. So I understand that in Alberta, that masks are distributed free of charge by the state. I understand that that's the practice in a number of other places, Belgium, Turkey, the state of Utah, in the US. Has that had a positive impact in Alberta, Canada? Could you comment on that?
Certainly, the experience I've seen is that people are more likely to wear masks if they are made available to them free of charge. Where I'm living, which is just across the border from Switzerland in France, there is not only a distribution by the local mayor, but also quite a lot of clear advice on when and how they should be worn, and I'm seeing a gradual pickup in wearing. It's not something that can be done immediately. People don't, especially if it's not compulsory, they don't immediately shift to doing it, but it's a kind of gradual process as people get used to doing it. Not everybody enjoys wearing a mask. They feel it interferes with communication. They may feel claustrophobic. We need to be tolerant of the reality that this is quite a new practice. But I'm seeing it pick up, especially where I have seen masks distributed free of charge.
Finally, just a quote, I'm not sure if I can pronounce the man's surname, George Gao, the head of the China Centre for Disease Control.
China, yeah.
He told the journal Science that the big mistake in the US and Europe is that people aren't wearing masks. Would you comment on that statement?
Oh, I'm super careful. Can I just say, I don't find it easy to ever look at what countries have done and ascribe difficulty to one issue. It's often a combination of issues that make it difficult to get on top of COVID. And because there's no single playbook, there's just accumulated experience that's been built up over time. It's now quite good. I think that we have to be careful. I personally have said that I believe that the use of face protection is a part of emerging from lockdowns and other stringent controls to being able to live with the virus.
Thank you, Deputy Barry. Dr. Nabarro, if I could just come in at this point. I have in front of me a document here. It's advice on the use of masks in the context of COVID-19, interim guidance from the World Health Organization on the 5th of June 2020, which is only 6 days ago. And it states it's divided in two. There's advice for healthcare workers, both healthcare workers dealing with COVID-19 patients and those not dealing with COVID-19 patients. And then there's advice to decision makers on the use of masks for the general public. And it says, many countries have recommended the use of fabric masks, face coverings for the general public. At the present time, the widespread use of masks by healthy people in the community setting is not yet supported by high quality or direct scientific evidence, and there are potential benefits and harms to consider, and they're set out thereafter. I just wonder, has there been a change in that WHO advice, or do you disagree with that WHO advice, or how do you reconcile that with what you said was your personal view on face coverings?
Just to be straight with you, and I mean totally candid, that particular guidance for me is not as clear as ideally I would wish it to be. Now, the reason is that this is an area where there is just a massive degree of disagreement. I mean, I think reading the news, even in Ireland, there's disagreement. You've got one group of people who say the science isn't very strong, plus also if you have people wearing masks widely, that will lead them to have a false sense of complacency that makes them take wrong choices. And then thirdly, there is an anxiety that people will get fed up of wearing masks and do it improperly, as I just described. On the other side, we've got people, and I belong to that camp, who feel that this is a proper part of an overall strategy, and that especially when people have to be close up, for example, in a commuter train or in a factory floor, then it's the right thing to do, and people will become responsible about mask wearing, and will do it in a way that is good. It may take them a bit of time. Why do I feel like that? Because I was working in Southeast Asia in 2003 and 2004 after the SARS outbreak, and I saw the role that face protections had. So I have now, in that response, slightly put myself on a bit of one side in relation to this even-handed guidance from WHO.
WHO official guidance is not as is more equivocal than your own view.
Yes.
Thank you.
Yes, and I think, you see, as an envoy of WHO, I'm not a member of the staff. I'm somebody who interprets WHO's guidance for different actors who ask me questions, and I accompany people while they're making decisions, also to help them. And this is an area where I have been quite clear on successive interviews and also in private discussions that I think the wearing of face masks is an important part of a comprehensive strategy, especially when you are in the state, as you are now in Ireland, emerging out of lockdown. It's quite delicate. and you want to be sure that you're doing everything possible to prevent there being new spikes. As we were asked, I was asked earlier, what will you look for? Well, you're going to be looking for increases in numbers of cases, and just need to try to do everything possible to stop that happening and have everybody on side with it. I hope that's clear.
It is,
and I hope I've been also helpful to you in showing where I sit in relation to the organisation.
Yes, thank you. You have. Just one last question with regard to commuters. You said it was reasonable for commuters to wear masks or face coverings. Do you think it's also reasonable, or would you go further in respect of staff, of bus drivers, attendants, etc., that they should wear a mask for their own protection? Or is it, would you say it's reasonable, or would you go further?
One of my particular concerns is that the people who seem to be most at risk of getting this disease in Western Europe and the US seem to be people who are providing services to others. So it is, as I say, security guards, it is cleaners, it is people who are driving vehicles, particularly multi-passenger vehicles. And I've always felt that these are the people who often have less opportunity to negotiate particular aspects of their working conditions and living conditions, because they are often poor paid. They may come from ethnic minorities, which may have additional challenges. So that's why I was really pleased, for example, in Geneva, when the decision was made to ask all drivers to wear face masks for their own protection, good fitting masks. I was pleased when I heard talk about in the UK that it was going to become mandatory for people to wear masks in London transport and indeed in other urban transport networks, only because I'm more concerned about protecting those whose jobs put them into some kind of regular exposure, as I do get very concerned about the inequities around this disease.
I'd now like to call upon Deputy Shanahan, please.
Dr. Nabarro, thank you for your contribution here this morning. As somebody who is a member of an independence grouping who has called for the use of face masks many, many weeks ago, I support your stand, and I think you're, hopefully what you're saying today may have repercussions here for national policy. Could I ask you just a more medical question, if you please? For the elderly, there's some suggestion that the elderly would have done a lot better in this country if we had been fortifying diets with vitamin D and zinc. Have you any comments to that, please?
Thank you very much indeed. Yes, I saw those, not just from Ireland, but from other countries, those suggestions that vitamin D would be helpful. I just have to answer, I don't know. I know that there's a lot of work underway, but I could not give you a precise recommendation to answer that question. Sorry.
And could I just ask you then, in terms of, and Ireland are following, as you say, a similar trajectory as other countries, just two things. One, in terms of the influenza season, which will probably kick in any time from October on, have you any thoughts about whether humidity increases the risk of, I suppose, aerosolization, or of the pathogen remaining aerosolized for longer, and whether that increases the risk of transmission? And could I also just ask you, in terms of the profiling of people who are affected by COVID, so as we come out and if we get a resurgence of disease, ideally we don't want to close down, and there are significant sectors of the population who are, they're not unaffected, but certainly they will, children for instance, who are not, don't have other underlying illnesses, will largely bounce back quickly from COVID, probably fit adults 20, 30, 40 years of age. Is it possible to profile the population and, let's say, look at a kind of segmented cocooning or otherwise, so that the economy doesn't have to close? Thanks.
Thanks very much. Can I just go to that second point and make a general statement here? I really hope that it will not be necessary for the whole economy of Ireland to close again as a result of COVID. Everything I'm reading suggests that by building up local level public health capacity, it looks as though Ireland is putting good protection and defence in place. That's what getting ahead of the virus means. I'm not too keen on cocooning sections of the population. Because I'm in the 70-plus age group, I don't want to be cocooned. I've just had my 5th grandchild born a couple of days ago. I very much want to see him. And so please, could we do our absolute best, if we are going to do population profiling, to avoid any kind of shut-up of any particular group of people. But I do agree with you that children appear, and I want to say appear, and please don't take this as a statement of policy or fact, appear not to have a central role in the transmission of the virus. However, it is also clear from data from South Korea recently that the school can be an epicenter where virus transmission can build up. So we just need to be quite careful to distinguish between what happens in the school as a meeting point and the role played by children. Lastly, I do believe that in humid, cold contexts, the droplets that carry the COVID virus tend to linger longer and travel a little bit further in the air than in hot, dry environments. So I do agree, therefore, that there will be some potentiation of transmission during the winter, and it'll be additionally complicated because flu is there at the same time, and differentiating will be difficult. I would just repeat what I said before, that I don't think this is seasonal. We just checked with others on the vitamin D and zinc issue, and as I thought, this is work in progress. Thank you.
Deputy Collins.
Thank you, Doctor, for being with us today. I have 4 questions, Doctor, and I might call out the 4 now so that I give you a chance here. What is the WHO stance on social distancing at the moment? Should we be maintaining the 2-metre distancing in Ireland, or is 1 metre sufficient? And the second question is, for those people who have had the COVID-19 virus, are they now immune, in your view, to the virus going forward? Third question is, what is the most recent view of clinical trials on the safety of hydroxychloroquine? And the fourth question is, does the WHO anticipate that home testing kits for COVID might be available for each household this autumn?
Thank you very much indeed. So tough ones. I did check with Dr. Michael Ryan, who is the head of WHO Health Emergencies Programme, an Irishman, this morning, because I knew that I would be asked to make an absolute position on, express an absolute position on 2 metres versus 1 metre. And Mike did remind me that these are fundamentally statements of risk. Number one, you have to take into account the context, how much virus is there around. Number two, you have to think about the actual location you're in. Is it closed or is it open? Because we believe that this virus is much more easily transmitted in closed locations. Number three, it's really important to recognise that there is certainly a risk of still being able to get the COVID if somebody in front of you is 1 metre away and is coughing in front of you. But that risk is 1 metre, possibly sort of 70% less than if you were really close to the person. If you go 2 metres, then the risk is down to about 85%, so or even 90%. So each time you add a metre, you're reducing the risk. And so in the end, choices do have to be made. How much risk of continued COVID infection are you prepared to tolerate? And that will be a decision that is taken by the national government, and it will be taken on the basis of multiple factors. Because we all know that maintaining the 2 metres does have costs, economic costs and social costs. And so I'm not prepared to stand to be here and say it is absolutely 1 metre or 2 metre, but I am prepared to say there is a considerable reduction in risk at 1 metre and a much greater reduction in risk at 2 metres. If you've had COVID, are you immune from getting it again? We don't know. And I wish I could answer the question yes or no. I've got family members who've had COVID. I wish I could be able to say to them that they don't need to take precautions, they won't be infected again. But I'm afraid it is just the case. We do not know yet. And thirdly, what about hydroxychloroquine? The clinical trials are underway. I think you'll know that the WHO trial on hydroxychloroquine was stopped for a period after a publication in the Lancet, another one in the New England Journal of Medicine, saying that hydroxychloroquine increased the risk. But then after review of these two papers, it was decided that the trials should go ahead. So we don't have the answer on the efficacy of hydroxychloroquine, either in prevention or in treatment of COVID. And will home testing kits be available? It is absolutely no doubt that in the coming weeks and months, there will be far greater availability of serology tests that tell whether or not people have got antibodies against this virus, and that will enable people to know whether they've had the disease. It won't tell them whether they're immune. So we anticipate that there will be much wider availability. We don't know what their cost is going to be, and also there are still only a small number of the kit manufacturers who've had their kits tested to make sure that they're reliable. I don't think we're anywhere near having home testing for virus, which would be the most useful one to have. And I suppose if there's one thing that I would love to appear as of a miracle, it would be a reliable home testing kit for virus that you could just do by taking a swab and putting it on some kind of stick and looking at the result. But that's not, I'm afraid, anywhere near production yet, as far as I know.
Dr. Nabarro, thank you, Deputy Collins. The next speaker is Deputy John McGuinness for 5 minutes.
Doctor, why is it that a lot of these viruses now originate in China? Would you comment on that? And in terms of how Japan reacted to this virus, COVID-19, and indeed Taiwan, quite close to China, and had a very successful outcome in controlling the virus, and indeed are now almost back to normal business. And they too applied masks, as they were mandated to have masks on public transport, and they reacted in a different way. Where is the science behind the notion about lockdown? Where is the proven analysis there that this type of lockdown that we applied here in Ireland actually works, related to the FARS law, where the Bell graph comes into clear sight? And in terms of transport, be it public transport or flights, air transport, particularly related to Ireland, how can we reopen safely that transport network, because we rely so heavily on it in terms of our tourism?
Thanks very much indeed. Most of the new viruses that emerge do come from animals. Actually, the H5N1 bird flu virus that I worked on in 2005, that seemed to emerge somewhere in the area around the Mekong River. So that was China plus other countries in that what used to be called Indo-China region, but now I would refer to the Mekong area. The H1N1 virus, of course, the last influenza pandemic, actually seemed to originate in Mexico, not in China. And so I wouldn't want to say that it's 100%. And we do think HIV originated from simian populations in Africa. So, yeah, some have emerged in China, but not all. But we basically believe that anywhere where humans and animals are in close juxtaposition, the virus can jump. The Ebola outbreak in West Africa, we think, came via a bat in the part of interior Guinea. So all the time we're looking at interactions between animals and humans. The countries that were really successful in East Asia at the beginning basically did have a dress rehearsal, and that was with SARS in 2003. And they learned just one basic reality about dealing with these coronaviruses, and that is you've got to stop the transmission immediately you see your first cases. Not necessarily with a whole lockdown, but you do have to focus on the area where the virus is, and you have to make certain that you interrupt transmission by isolating people, finding their contacts and isolating them. It's the basic rule of dealing with infectious diseases. As you mentioned, Taiwan was successful. Japan, it was tricky at the beginning. It wasn't straight away an enormous success, but they did get it right and have got it right. South Korea the same, though they've still got resurgent cases from importation, and they know that they can't kind of keep their borders shut and hermetically sealed, so they've got to maintain the defences. But it has been rapid and been robust at the very beginning. Because of the exponential spread of these viruses, if you delay 1 month, 1 week, 2 weeks, 3 weeks, 4 weeks, even 5 weeks before you're taking it seriously, you have an absolutely massive problem, and you end up with virus in multiple locations. And that's why certain countries that have been slow to act have got much, much bigger challenges. And so you're right, I believe, to point to the fact that it is rapid action that really matters. Just on lockdown, I want to stress that when you put a country into lockdown, when you've got a lot of virus, what it does is it holds the virus in place. But the actual process of getting rid of the virus is all about interrupting transmission through case detection, through testing, and then isolation with special attention in high-risk areas. So I don't see lockdown primarily as a control measure. It buys you time while you put the other pieces in place, as has been done in Ireland and as you're planning going forward. How will flights reopen? I think there will be analyses by countries of destination places saying, is their risk profile the same as ours? Are they taking the same basic strategy to us? Have they got their level of disease down in the way that we have, so that the incidence is at the same sort of level? If yes, then we create an open corridor and do not put quarantine in there. But obviously, if they've got a lot more disease, then we're going to be rather careful of people coming from their country, so we might have some kind of quarantine. Or if they've got a lot more, if they've got a lot more disease, we might do that. If by chance we've got more disease than they have, then they might ask to go into quarantine. But I just don't think that the blanket two weeks quarantine is going to stick in any part of Europe. I think it will be much more on a negotiated basis between countries, with very careful discussions between public health experts either side to try to check that they've got equivalent risk profiles.
Nabarro, thank you very much. Deputy O'Dowd, 5 minutes.
Can I just ask you a couple of questions? The first one has got a bit 2 parts in it. One of the problems with masks, if you go to buy them, you don't know what quality they are. So there isn't a CE mark or a quality assurance that I can find that will make certainty about the quality mask you want to purchase. And I address that to the fact that the WHO are now saying that over 60s must have medical grade masks, and I think that's a huge change in approach, because the age cohort that we're talking about before that was over 70. So is there a new and emerging risk for people over 60? And if they're required to wear these masks for all social interaction or for shopping, I know they don't wear them at home, you don't wear them in the open, but it's going to be a huge burden, particularly on low-income people, to get the masks and to wear them. I would assume they would need hundreds over a year. The second question I have is in relation to deaths in nursing homes. And what I've read, and I'm glad that you're the expert, but as I understand it, in Hong Kong, there were no deaths in nursing homes in Hong Kong, and it appears the way they dealt with it, it's an article from The Guardian that I read, the way they dealt with, if you were COVID positive, you went from a nursing home into an acute hospital or into medium-term isolation. So to prevent this awful, evil virus coming back and attacking and killing people in our nursing homes, is there a need for best practice to emanate from you people in the WHO
to make sure that we change the way we deal with people who are positive, that we don't keep them in nursing homes if it's better that they go to an acute hospital or a different type of isolation. And the last point is, in Ireland, over 60% of our nursing homes do not conform to all the regulations. Now, I accept and acknowledge that the virus can strike anywhere at any time, but surely we need the international best practice should be that whatever the standards are in any country for nursing homes, they should meet 100% of those regulations to save lives. Thank you.
So thank you. The second question is tough because, this is national policy issues. So I want to just, again, talk to you really from my personal and professional perspective here. I think it is really important that there is best practice in nursing homes and that everything possible is done to ensure that there is really strong infection control for the residents. This is necessary for the sake of relatives, it's necessary for the sake of the staff, and I personally think it's a sign of a good society that we treat everybody, whether they're old or young, with the same respect when it comes to life. So I agree with you that there is a need for universal application of best practice wherever possible. I think we also have to recognise that good infection control in nursing homes is not easy, as I said before, because of aspects of how they are. Lastly, I do think there needs to be clear good practice. I don't necessarily think that means you take people to hospital the moment they've got COVID, but I do think it means that you put them in really proper facilities for isolation. If you don't isolate them, then everybody else gets the COVID. And we've got so much evidence now that dormitory wards in nursing homes very quickly become places where just about everybody gets infected. So as soon as somebody has got the COVID, so you need to test quite often, that they should certainly be isolated. Whether you take them to a hospital or not, I think that's a local decision. I totally agree with you that now that the WHO guidance has come out saying that these quality masks, I've got one here, it's an FFP mask, they are quite different from the sort of fabric masks, and people are saying that these quality masks should be used by older people. There is a cost to these, and I agree with you that that has to be taken into account. Lastly, like you, I agree that face protections using fabric, ideally there ought to be some kind of statement as to what they're made up of, either in terms of numbers of layers of tissue that's in there, of cloth that's in there, or if even better, some kind of kite mark. I agree with you on that as well. So I find myself agreeing with all the points you've raised.
And thank you, Deputy O'Dowd. Deputy O'Rourke.
Thank you very much, Dr. Nabarro, for your contribution, and to thank you in particular for your comments in relation to face coverings and face masks. You'll be aware that there's a significant debate here at this point in time. Am I right in saying there's also a significant debate in relation to the social distancing and the 2 metres versus 1 metre discussion? Am I right in saying that if it were the decision to move from 2 metres to 1 metre, that it increases the importance of the likes of compulsory face masks and face masks in enclosed spaces as part of the cumulative playbook? On the same issue, do you think temperature checks and antibody tests have a role, and what role in relation to that cumulative playbook, particularly at our ports and airports?
Thanks very much. We'll start, therefore, in addressing this. When are people most likely to transmit the COVID? Answer: in the day or so before they develop their symptoms. That's one of the reasons why this is a tricky virus to deal with. The SARS tended to be symptomatic transmission. COVID seems to be a bit more pre-symptomatic transmission. And as you might know, there's also a bit of debate about whether people who never have symptoms can actually be transmitting the virus. So if that's a reality, that the people just before they get the disease are still potentially really quite infectious, then I agree with you totally. The comprehensive package is important. And I just wanted to come back to the previous question, I think, from Dr. McGuinness. Yes, I think face masks have been a super important part of the comprehensive package in East Asia. You called it the cumulative playbook. I like the fact that legislators are recognising it's not one or the other. It's all of the different pieces together. We just can't pick out any single approach that makes all the difference. And face protection does seem to be a part of it. But on the 1 metre versus 2 metres, I want to say it again, but I'll try a slightly different way. Essentially, if you want to be really sure that you're not going to get infected by somebody who's got COVID, you stay a long way away from them, possibly 3 or 4 metres, because you just don't know when they're coughing whether or not there'll be one droplet that flies across in the air, gets what we call aerosolized, and you just happen to have the bad luck to get it. I have a very close friend who believes that she got her COVID in a supermarket in Brighton where there was aerosolized transmission. So super sure, you need to be quite a long way away. Then the closer you become to the person who's got the COVID, the more likely you are to get infected. So at 2 metres, we're currently saying you're sort of between 85 and 95% likely to be protected, but there's still an outside chance that you might get it. But when you get up to 1 metre, we think it drops down to between 70 and 80%. And of course, the likelihood will increase if it's a closed environment. Like one of the things we've found out is that karaoke bars are particularly difficult places because they're closed, but also because people sing and shout. And we found that when people sing and shout, particularly very loudly, belting out a song, they are then able to transmit much more easily. So it's all a question of risk, and it depends so much on how people are actually behaving.
Nabarro, thanks, Dr. Nabarro. I might move on. Thanks for that response. I just wanted to raise one other issue with you, and it's in relation to fair and equitable access to COVID-19 technologies, vaccines, treatments. And I note the WHO's technology access pool. And I just want you maybe to speak to that as an initiative, the response of governments and what sort of response you've had from the Irish government and what sort of response you would like from the Irish government.
Thank you very much indeed, super fast. There's no point in having new technologies for something like COVID unless they're available to everybody, regardless of wealth, regardless of race, regardless of nationality. To have a situation where only people from rich countries or only people who've got a lot of cash in their pocket can get access to things that will really save their lives or prevent them from being exposed to a dangerous disease is just wrong. It's unethical. Irish government has been unequivocal on this. I'm really pleased, and the position has obviously been the right one. I think that the proposal that came originally from Costa Rica for a technology access pool did find its way into the resolution of the World Health Assembly on the 19th of May. It was not pushed out by any country, but what matters not so much is what's in the resolution, it's what countries do. And I'm still concerned that there are some rich countries that are apparently buying up and making advanced purchases of vaccines and also buying up a lot of treatments that might be effective for their own people and their own friends. And I would seriously encourage every country, and Ireland must, I think, continue to be in the lead on this, as it has been on so many other issues, to go for equity of access everywhere. You asked about antibody tests. They're only useful for finding out who's got the disease. They're not useful in actually dealing with who might have the disease at the present time. And temperature checks, unfortunately, are only picking up people possibly 1 or 2 or 3 days after they've been infectious.
Dr. Nabarro, and just following up on the technology access pool, can we just get a sense of how its work is developing, the practical implications it will have in terms of the products that are developed, the technologies, the vaccines that are developed for COVID-19, and the implications for the patents and the availability of those products for citizens across the globe?
So the way in which this will work will depend entirely on whether or not governments are prepared to actually buy into it and to work with it in practice. As you know, in other issues where we've had patents on medicines or on particular devices, it has required the patent holder to cede their rights so that they make it available in a wider way. There are certain provisions in WTO, World Trade Organization legislation, for what's called emergency licensing of patented goods that can be applied. But fundamentally, this only works by the consent of the patent-holding companies and the nations within which they exist. The current situation, for me, just looking at it as a bit of an outside observer, because this is between the member states, it's not the Secretariat that deals with it, is as follows. I'm seeing strong support from many governments for broader access and for not having intellectual property stand in the way of access. But there are still some major nations that are not fully participating. What I would encourage, particularly given Ireland's role on the international stage, is that Ireland does take responsibility for advancing this as fully as possible in the different political environments, particularly through your permanent representative in New York, working with other permanent representatives, but perhaps in debate with the UN Secretary General, because that is the only venue, I believe, where these kind of issues can be dealt with. Yes, we can deal with them in the World Health Assembly, but in the end, it's in the United Nations machinery that is where, particularly, I mean, for example, when we were dealing with access to AIDS medicines, it was there that the work was actually done, and I would like to encourage the same.
Thank you, Dr. Nabarro. Thank you, Deputy O'Rourke. Deputy Donnelly.
Isn't coming in for us. Does that? Can we take the two?
No, you've got 5 minutes each, as opposed to 16 minutes between four of you, so it's the same.
So can I take Deputy Foley's time?
No,
she's not coming in.
You've got 5 minutes, as opposed to 4 fours. You have 3 5s.
Oh, I beg your pardon. Thank you. Dr. Nabarro, thank you very much for your time. It's been a really enlightening session. Can I ask you 3 questions? The first is gender impact. So we know that COVID has been much more fatal for men globally. Globally, the figure is 38% of the deaths have been women. In Ireland, that 38% is 57%. We have a massive additional fatality rate for women. I'm wondering if you can provide us with any insight into why that is happening, and are there structural changes we could make that could do something about this? The second issue is around border controls. You referenced the letter from the 1,000 scientists. They're making a very strong case for increased border controls. And there are other groups within the country, be it in hospitality, business and others, who are very understandably looking for looser border controls. If you were advising the Irish government on what to do for the next, let's say, 3 months, what would your advice be? Would it be mandatory rapid testing in airports? Would it be mandatory self-isolation? Would it be to relax the self-isolation, pick a small number of countries and have the so-called air bridges with them? What would your advice be? Obviously, as an island nation, getting the border controls right is very important. And then finally, there's been a discussion this morning about our fatality rate in Ireland versus other countries. And I think you quite rightly said that Ireland has done a lot of things right. It moved quickly on a lot of issues. And yet, when you look at our COVID fatality rate, whilst we have fared considerably better than some countries like the United Kingdom and France and Italy, we have fared significantly worse than a lot of other European countries like Germany, Austria, Finland, Greece, Portugal, etc. Given that we appear to have done a lot of things right, as we plan for a second wave, which hopefully won't come, what can we learn from the European countries that seem to have fared significantly better than we have? Thank you.
Thanks very much indeed. I noticed that you've got rather a different distribution of mortality between women and men in Ireland compared with other countries. And I don't know the answer. What I do know is that this is the subject of quite deep and careful investigation, and the sort of issues to be looked at are related to underlying conditions, whether there was any difference between men and women in access to healthcare and the like. So I don't want to speculate. I think it would be wrong just because I don't know. But I do want to say that I do hope that care is taken to make sure that women and men are getting the same attention when they're ill. You know, we've found in other conditions like myocardial infarction that for some reason in some countries women present for care later than men do, and that leads to worse outcomes. We've also found, just as an aside, and I'm not taking up too much time, that although COVID is more fatal for men, that the actual containment measures tend to be much worse for women. They suffer more. And so I think that the whole gender issues in relation to COVID need to be looked at with great care. If I was advising the Government of Ireland, I would actually suggest to look, when deciding about air travel, for equalisation of risk. So I would set up air bridges with countries where I felt the COVID prevalence and in the community was about the same. The incidence figures of new cases were about the same, and the capacity to deal with outbreaks is compatible in the two countries. And then I would set up the air bridge and I would keep it reviewed at regular intervals. I just think it's not appropriate to have a single blanket recommendation for everybody, at least not at this time. But yet, I do understand this debate, that there will be some people who say you've got to get to zero and keep it at zero, which means having really tight border controls. And there will be others who are saying, well, hang on a bit, you know, we have a country that is dependent on international connections, and we've got to perhaps have a slightly different level of risk that we tolerate. And I would work really hard not to actually make the decision, because I think that's what politicians like yourselves are elected to do. But I would be offering the advice, and I would say you have to just balance these things against each other, and creating a kind of a curtain around Ireland and saying, sorry, that's it. You only come in if you've stuck around for 2 weeks, either self-isolation or in a quarantine, then that's the only way you can come in. I would just want to say there are going to be major disadvantages of that kind of approach. Rapid testing at the airport is not really on. We haven't got a rapid test you can do, and I think having PCR testing at the airport might work, and that's something that might be done. It will require considerable investment.
Thank you, Dr. Nabarro. Thank you. I'm going to have to...
on the high fertility rate, I just want to stress that you are counting more than other countries, and that's the reason why I think it's higher. Over.
Thank you. Thank you very much. Deputy Carol McNeill.
Thank you, Dr. Nabarro, for being with us today. If I could just ask you two health questions. It's clear that having an underlying condition may exacerbate your experience of the virus if you do contract it, an underlying condition such as a heart condition or a respiratory condition. If it's to be the case that we're going to have to live with coronavirus for some time, one of the things I'm concerned about is what underlying conditions may increase the chance of you contracting the disease in the first instance. So, for example, we've seen the National Council for the Blind in Ireland observe that people who are blind or otherwise vision impaired just can't socially distance in the same way or be expected to socially distance all the time or physically distance. And I'm also concerned about people with neurological conditions, dementia and others, where it's difficult to remember or process information in the same way. And obviously this is complex and evolving public health information. Could I ask you also about, appreciate this is the earliest point in a complex virus, but do we have any sense or perception yet of what the long-term implications of the coronavirus might be on an individual who has had it and recovered?
Thank you for both questions. questions, people who are blind, people who are disabled and need personal care, as you say, people who are demented, people who are mentally ill, people who are just frankly claustrophobic. All these are going to be situations in which the risk will be greater of contracting the virus. I don't know myself of any physical conditions that will make people more likely to be infected as opposed to physical conditions that make them more likely to suffer more seriously. I think I need a bit of a notice on that one. I am seeing increasing numbers of reports of people who have had COVID and then have either had a really, really long and difficult recovery or actually have just not recovered yet at all. These include people I know. And so it's become quite personal for me. One of the things is that a very long period of being extremely tired so that they just cannot walk to the shops, they cannot concentrate on their work. I got one colleague, a professor, had it 2 months ago as far as I can remember. I remember being with him on a Zoom seminar and he said he was feeling rotten and I said, I think you've got the COVID and you better go and isolate. And it turned out he had. And he's still finding it hard. And he's encountering many others who are telling him that it's difficult. So I just think we need to hold on to this, that for an awful lot of people, this is not a trivial illness from which they recover. And there's a long post-stromal period. Secondly, I've got a number of friends and colleagues who are physically fit and who do a lot of exercise. And then when they've had their COVID, there's quite a long period in which they remain short of breath on exertion, and some of them perceive that they may actually have long-term lung damage. So keep a lookout for that. And thirdly, as I think you've heard, there are people who, because of the effect of COVID on blood vessels, get clots in their bloodstream, which then can go and give them a stroke or even a heart attack. And so I want to stress that I think we're just at the beginning of understanding both the overall pathology of this in terms of the kind of illnesses it can cause and also the long-term sequelae of this. And I would ask all employers and family members to be very patient if somebody's had COVID and is clearly still struggling. That's not because they are in any way just malingering. That may well be because this is what this disease seems to do to some. It makes them unwell and unable to function fully for quite a long time. I'm so grateful to you for asking that question.
Because that is what I'm concerned about precisely, because you could have the illusion of recovery from having been discharged from hospital or appearing to be better, but actually very significantly unwell for quite a period with implications both within your family and for your employer. And so that is what I'm trying to understand exactly. I only have a very short period, but I'm terribly interested in... I'm sorry, go on.
Yep.
I'm really interested in what you... I know you've been studying the global progress of the pandemic. Clearly, population distribution has had a major impact, I understand, in terms of how different countries have experienced it. Could you just give us some, I only have a short time, very short thoughts on the role of population distribution or why some countries have experienced it so differently to others, not just in terms of how they've reacted?
The structure of the population, you're absolutely right. But again, poor countries seem to be having, in some cases, quite different illness profile from COVID. I've heard reports, still anecdotal, of great increases in cardiovascular disease and heart attack rates and other such things. So I still think there's a real need not to imagine that poor countries are getting off lightly. I don't think they are.
Thank you, Deputy Carroll. Dr. Nabarro, I just have a couple of questions myself, if I may. You very fairly pointed out a difference of emphasis between your own view and the WHO guidance on masks in particular. But returning to your own view, you said that it was particularly important for service providers and transport workers to be protected. Is it more important that they wear masks or that the general public wear masks, or is that a false dichotomy?
Well, actually, I was thinking about, when you asked it before a bit, I was wondering, you know, obviously, if I am a bus driver my real risk comes from other people in my bus, particularly if it's crowded, being close to where I'm driving and coughing close to me. And we know that face protection is quite useful for preventing somebody who's got illness from passing it to others. And if people are not responsible and staying at home when they're ill, or if they're just in the process of becoming ill with COVID, then it's a decent thing to do to wear a mask to protect the person who's serving you. So that is my fundamental point on this. And I think I want to go on saying that again and again and again, because I don't think it's fully understood. I was saying to a colleague the other day, if they're going to open restaurants in France and have people indoors, then the diners ought to be wearing masks to protect the waiters. And my friend said, no way that will ever happen. But I said, from a logical point of view of being responsible, it's the people who serve us that we need to protect. So I hope I don't think it's a moot point. I think it really is about respect for those who serve us, who often have no choice but to do the work because they're poor and they've suffered huge income losses due to lockdowns and so on. And so it's part of being, I think, really responsible.
Thank you. Just one other question, and that's with regard again, and I don't wish to point out differences of view between your own personal view and the WHO guidance, but there's considerations for public health and social measures in the workplace, WHO guidance of the 10th of May of this year, and they say that physical distancing at least 1 metre apart for workstations, common spaces, and where congregation or queuing of employees or visitors might occur. Now, you have said 2 metres is safer, 4 metres is safer again. Could I ask then, why does the WHO say at least 1 metre rather than at least 2 or at least 4, or no congregations indoors?
I think in all the advice that comes from an organisation like WHO, they really do have to offer the best information on which others can then make decisions. Remember that the WHO is not an enforcement agency. I think on this one, they have worked really hard to recognise that for the majority of people in our world, particularly in poor places, the thought of living with 2 metres distancing is just completely out of the question. And if they did have that as part of their guidance, they would be accused of being completely out of touch and they would have been ridiculed. That was my understanding of it. But there is one other thing that I discussed this morning with Dr. Ryan, which he felt that I ought to get across. He reminded me that there's a huge difference between being with somebody who's got the COVID for, say, 4 or 5 hours while they're coughing and before they manage to get home and isolate themselves, or being with somebody who's got COVID for 5 minutes. You are so much more likely to get infected if there's a long period of exposure. And so I think that both Mike and I would like to share with you all that if you're going to see a reduction in the distance to 1 metre, just bear in mind that if there is a prolonged exposure at these shorter distances, that really does greatly increase the risk. So there is, I think, a need to once again look at things like workplaces and say that perhaps in a place of work where people are spending more time together, then a slightly greater distance makes sense. I hope that's clear, and I hope you don't mind me trying to put it in a bit more into context, because in actual practice, over time, it won't be authorities that tell us how close we're going to be able to be to each other. It's going to be we ourselves who have to make the choices in our workplaces, in our social lives, in our families. And I think you've heard whenever I've been speaking or in my media work, I am trying to all the time help people have whatever information I've got so that they're enabled to make their own judgments.
Thank you.
Because in the end, it'll be up to all of us how we deal with this threat.
I know you're under time pressure. I just wonder whether you have time to answer 2 brief questions. If you do, great. One for myself, one for my colleague Deputy Brophy, but if you don't, I understand.
I'm just checking, but I think I left a little buffer just in case this happened. Okay. And I did. And I want to stress, it is my absolute privilege to go on. So I'm putting the next one back just by 10 minutes. Thank you.
Okay, thank you. Is cancer screening a very dangerous procedure for healthcare providers to engage in, such that would justify the suspension of all cancer screening activity for months on end in a country like Ireland where PPE is available?
So one of the things that I've noticed is that the reaction of healthcare providers at the beginning, when they're starting to deal with COVID, has been quite absolutist, and quite a lot of procedures which might be called routine, though I would not say screening for cancer is routine, have been suspended. Even in some places, maternity support services like antenatal care have been suspended. I'm not talking about Ireland, I'm talking about more generally. Then over time, as the professionals have got their routines sorted out, have changed their patterns of flow in the hospital, have got adequate PPE, have managed to get their shift times right, have dealt with also any possible accidental infection that might occur for those who are providing support services like porters and cleaners, then it's become possible for them to adapt and readjust. And I think there'll be more and more of this happening. So whilst there might have been, in some settings, a cessation of screening procedures and even treatment procedures for people with chronic diseases that require ongoing attention, after, say, a month or two, things have settled down and new systems have been developed. So I would expect, in places where cancer screening has been stopped, that over time, and it'd be quite quickly, that there will be a sorting out. Just as in schools, there's a lot of questioning about what to do about schools and a lot of uncertainty. And I would expect that gradually as we get into this, the procedures will be established and things will get better. And anyway, we'll be informed by more science. So in answer to your question, I don't want to be absolute. I want to say it will come good. It will just take a little bit of time.
Deputy Brophy.
Thank you for giving this little bit of extra time to us to ask this question. I want to ask a very specific question on the travel side, which follows up on an answer you gave earlier on. There is a lot of people who are contacting me at the moment about this air bridge idea, the European Union trying to open up a common travel area. And they're really concerned and worried and, to be honest, confused about why or is it commercially driven, they're asking, why the European Union would be particularly saying, and why you seem to be saying, that it is right to bring people from all over Europe now together during a holiday season of July and August, have those people then disperse back to all the European countries they come from, even if there is a low rate present at the moment. Is this really a decision that is a safe decision? Is it being driven primarily by countries which had very bad, in some instances, COVID outbreaks, wanting, for economic reasons, to re-stimulate their economy through tourism? And is it actually safe for Irish people to travel to the Spains and Italys of this world this summer, to have a holiday, which may be a week or two, and then to come back to their home countries? If we're taking out the quarantining and if we're introducing the air bridges, is that really safe, or is that an economic decision?
I want to add a third dimension to it, that also people might well be wanting themselves to travel for their own personal reasons. They may have decided that this is important for their well-being, and I wouldn't want to judge that. Of course, what you're saying has a lot of truth to it. The situation in Spain as a result of COVID and lockdown and so on, with their dependence on tourism, is particularly bad for poor people. And so there is inevitably both personal and political pressure to reopen the tourist industry. As I'm sure it is in Ireland, there must be people all over the country who are really struggling because the expected tourist income is just not coming in. And so, yes, there will be economic pressures for opening up all round. And I'm kind of trying very hard not to say that that's wrong, because I appreciate it, and I'm hearing from so many people how much pain there is. So in the end, you as legislators and the authorities in the government do have to weigh up personal wish, the economic issues, and the health threats. I heard you say one thing, and I want to pick up on that. You said, is it all right to bring people together from all over Europe, expose them to risk and have them disperse again? I think if it was like that, I would be super worried. I think the only rational basis for establishing air bridges is after a very careful and independent assessment of the risk in the different locations and trying to make absolutely certain that this is done fairly. So, for example, let's say country X is setting up air bridges with 3 or 4 countries in Europe, A, B, C, D, E. It would be absolutely essential to ensure that the risk level in A, B, C, D, E, as well as in X, was absolutely compatible. And it would be totally wrong if suddenly it turned out that there'd been a mistake, perhaps caused by what you describe as economic pressure.
Thank you,
And
Dr.
also
Nabarro.
necessary to keep this under examination all the time because things can change. Okay, that's it. Thank you.
Just in response to my last question, you said that you expect to see schools and education facilities opening quickly. Do you expect that the 2-metre distancing will be maintained in schools and that will be respected, or that will be the norm across Europe and the developed world?
Well, that's me looking into the future. I mean, most importantly, I think that when it comes to schools, we need to be doing everything for the adults who congregate at the school place, whether they're teachers or parents or anybody else, because that's where I think the major potential for spread is going to happen. Secondly, obviously, it is necessary to try to ensure the best possible education experience for children. I'm one of those people who's been distressed by the number of months that children have lost for their education at all ages. Will it be 2 metres or 1 metre in school? Well, between the children, I understand that the approach is one of bubbles, and I think that that's a very promising one, and I expect that to remain. But I suspect that for the teachers and for the parents, the rule in schools will be the same as the rule everywhere else. And if there is a decision to try to move from 2 metres to 1 metre for any reason at all, then I'm sure that will take place in the schools as well. But I just encourage everybody, because this is my last word, just please stick with the basic principle that it's a comprehensive package of interventions that we have to use to keep the threat low. And if there is going to be a decision to get it down to 0, then that comprehensive package has to be super strong and maintained for a long time, and it will include also action at borders, because that's the only way you can keep it at 0. If there's going to be a willingness to tolerate it, there will be some cases appearing, but they'll be dealt with very quickly at local level by well-organised local authorities, coordinated with others. Then that will become the norm, and there will be odd cases, but they'll be managed very, very fast. But I would like to just really ensure that whatever standards are adopted, they are adopted wholeheartedly across the country. And then if there is a need for adaptation because of a local flare-up, that everybody understands why that is happening, using the kind of indicators that I know the government is looking at.
Thank you very much, Dr. Nabarro.
I hope this was some help.
Thank you very much for your time. Thank you for the extra time. Congratulations on the recent birth of your grandson, and I hope you can meet him soon. Thank you.
Just also a real appreciation to the people of Ireland. You know, I do rate what you've done really at a very high level, because you're human and the way you do it is full of humanity, because you do follow the science, but also because you're trying to be good European and global citizens, and it's fabulous to have the chance to spend so long with you all. I wish